Hi, thank you for joining Becoming a Doctor's tutorial today. Today we're being joined by Dr. James Warner, who'll be giving us a presentation on delirium. And we're just going to give it like a minute or two for people to come and join in, and then we'll go ahead. Off to you, James.
Okay, can we start? Right, good evening, everyone, and thank you very much for coming to this lecture. Now, I'm going to confess right at the beginning, I'm not a great fan of didactic lectures. I would much rather answer your questions. So if you want to send me some comments or questions, I'll do my best as we go along to answer these. I'm also conscious that it's 7 o'clock in the evening and many of you have got other things to do later on. So I'm probably going to stick to try and finish by 7:45. If we spill over a bit, I do apologize for that. A bit about me, very little bit about me. I'm a consultant psychiatrist. I've been a consultant for well over 20 years now. And I specialize in old age psychiatry, and I've worked right across the piece. So I've run community teams, acute inpatient wards, and for the last 5 years, a liaison psychiatrist in a busy central London general hospital, acute hospital. So that's me, right. So we're going to talk about delirium. And delirium, I think the reason I wanted to talk to you about this is one thing that as an F1, I guarantee you're going to be kept up all night by at least one patient with a florid delirium that is going to really drive a coach and horses through your plans for that evening. You know, whatever else is going on, you're going to get repeated phone calls from the nursing staff on the ward saying you've got to come and do something about this person. This will happen. If it doesn't, track me down, email me and say, I'm the one person this has not happened to. It will, as an F1 and as an F2 in acute medicine or acute surgery. Now, delirium has got a number of different monikers. It's also known as acute confusional state, and really those two terms are interchangeable. And the clue is in the tin. It is acute and people are confused. I personally prefer delirium. Most of the publications that you will see are refer to delirium, but acute confusional state is appropriate. These other things, these other phrases, have been said to me by fairly daring F1s, I have to say, and are not acceptable. Pleasantly confused. Pleasantly confused drives me mad, if you pardon the pun. It doesn't mean anything except someone is confused and not causing difficulties. And by saying pleasantly confused, you're devaluing the fact that they are confused. Run from your mind the notion that being confused is okay. Being confused is an important sign that has to be explored. Acutely mad, well, I'm not going to say anything more about that except, yeah, don't say it. Very aggressive. People are aggressive for a number of reasons. It might be a personality trait of theirs. It might be that they've had some frontal brain insult. If someone suddenly becomes very aggressive, it's delirium until proven otherwise. Track down, refine your diagnosis. Don't call them aggressive. Say, this person has delirium. Acute dementia is another one that's thrown at me from time to time. You can't have acute dementia. Well, you can, but we won't. That's another lecture. Dementia, according to the ICD-10, you have to be symptomatic for 6 months. So unless someone is symptomatic for 6 months, you can't call it dementia. I have seen occasionally individuals go from having entirely normal cognitive function to having dementia following a single strategic stroke, which is usually an infratentorial stroke, thalamic or pontine stroke, and they suddenly become very confused, and that becomes a dementia, but we don't really use the term. So delirium or acute confusional state is where we're at. And I quite like the DSM, the Diagnostic and Statistical Manual. This is the American Bible, but I think it sums up delirium really well. So 3 criteria, A, B, C. A is a disturbance in attention. Now, we've all seen this, but people don't often twig what attention is. Attention is when, and I'm sure this has happened to you when you've been talking to patients, it's when you're on the ward, you're having a chat with a patient, and suddenly they close their eyes, or they wander off the topic, or they just become distracted. They're not focused on the topic of conversation. You might be taking a medical history from them. You might be asking them about pain, and suddenly they're not in the room with you. I like that phrase, not in the room. That is a lack of attention. If you see that in someone, think delirium. And then you get reduced orientation, temporal and environmental orientation, what the DSM call awareness. If you have that, and it's come on suddenly, and by suddenly, we're talking about hours to days, not longer. And usually, delirium starts over hours. Usually, you've admitted someone, they're on the ward, everything's fine. You go and have your dinner, and you get a call from the staff. Someone's gone very confused. That is delirium. And it's a change from baseline. And the other thing that I really like about this definition is the fluctuation. And the fluctuation is a real hallmark of delirium. People are not the same over the 24-hour period. And it will tend to be that the delirium becomes more florid as the evening goes on. And over the nighttime hours, it is extremely significant. And you're up all night trying to control this situation, trying to contain this person, trying to work out the best way to manage them. And then at 8 o'clock in the morning, the consultant comes round for the post-take ward round, and the patient's sitting there, nice as pie, cup of tea in their hand, saying, "Oh, good morning, doctor, how are you?" And you think, what? Is this the same person that I was seeing 3 hours ago? That level of fluctuation, delirium. And then the other thing that you often get is these other disturbances in brain function. People will become, they will develop memory difficulties sometimes, occasionally issues around language. The thing that's missing here, which I think is quite important, is that you sometimes see quite significant changes in affect. And I have misdiagnosed someone as having a severe depression on the basis of their mental state. And in fact, it turned out to be a delirium with a very strong affective overlay. So you do get people who appear either hypomanic or depressed as part of being delirious. And then the other thing, which is really quite common, is abnormalities of perception. So people will hallucinate, and often visual hallucinations. Right, no questions yet. Please start asking questions if you want to. And then a couple of things that I would take to task with the DSM about a little bit, and I'll explain why. So they say that the criteria A and C, so just to remind you, disturbance of attention and awareness and the cognition, are not better explained by pre-existing neurocognitive disorder. I take issue with that because one of the biggest risk factors for developing delirium is dementia. And so you often see a pre-existing neurocognitive disorder in individuals with delirium. The point is that this is a change from baseline. So if someone's come in, they might have a mild dementia, they might be scoring 20, 21, 22 on the Montreal, and then suddenly they become much more confused, disorientated, inattentive, and hallucinating. That change in baseline. But it's wrong, I think, to say that if you have an established neurocognitive disorder, you can't have delirium. That's not right. And the other thing is that there's evidence of a physiological consequence of a medical condition or intoxication. That is absolutely correct. Delirium has causes. It is not something that arises de novo for no reason. But, and it's a big but, you can't always find that cause. You might look very assiduously, and it's not until the second or third or fourth day that you suddenly find, oh yeah, they've had a small stroke, or they've got an autoimmune encephalitis. These rarer causes of delirium can be difficult to track down. Okay, so here's a vignette for you. This is Helen. This is a real story. This is a woman who was admitted to Chelsea Westminster Hospital, retired librarian, lived alone, never married, admitted following a hip fracture and a bit of a long lie. So she had a bit of rhabdomyolysis and some mild renal impairment, but really nothing to write home about. Had a total hip replacement, and for the first 48 hours following that, was making a very good post-operative recovery, was beginning to mobilize. And then suddenly one evening about 7 o'clock, bang, sudden onset of confusion, very disorientated, became very paranoid, said that the nurses weren't real nurses, that she was on a film set, that everything had been contrived. Contrived was a word she used several times. She was a librarian, of course, she didn't use big words, but everything was contrived and not real. She was quite sure about that. And she was actively hallucinating. While I was talking to her, she was saying, look at those squirrels on the bed. Look at how they're playing around. And she could describe these squirrels in some detail. They were colorful, they were mobile, and they were making noises. And very importantly, there was nothing there to that might make this an illusion. So just to remind you, the difference between an illusion and a hallucination. An illusion has a stimulus. So I saw another patient, not Helen, another patient who saw a box of chocolates on the shelf by the bed and thought that was a hedgehog. But she was misinterpreting the box of chocolates as a hedgehog. That is an illusion. Helen was hallucinating. There was nothing on the bed that might make you think, well, that could be misinterpreted as a squirrel. And usually when things are moving around, they're not illusory, they're hallucinatory. So mental state examination of Helen, she was aroused and attentive, she was very disorientated, and she had this persecutory ideation. One of the things that she kept telling me was that there was a fire detector in the ceiling, and she thought that wasn't a fire detector, it was a camera pointing at her, and it was monitoring her. We managed to track down a friend who said that there were no prior cognitive symptoms, that she was functioning extremely well. She volunteered as a prison visitor and was very active in the local church, and these activities had continued up until the hip fracture. So we had no evidence of pre-existing cognitive impairment with Helen. So diagnosis of delirium. If anyone's out there, if anyone's listening to this, and maybe no one, I might be talking to myself here, which in COVID times I understand is quite normal. But does anyone want to just hammer out a couple of causes? Given what you've heard about Helen, what do you think those causes might have caused her delirium? I'll give you. Yes, no. Am I looking at this right? I've got. Can you see any comments? No. Right. 2 comments. Have we? Yeah, I've got them. Sorry, right, I have. Yeah. So, how can you right? So let me go through these. So, how can you differentiate between delirium and dementia for a patient you might not have seen before? Okay, good question. History. You pick up the phone and you speak to someone and say, has this person been confused before? Just like we did with Helen. How can you misdiagnose delirium and depression? Won't you need a long history for depression whilst delirium is acute and short? I'm going to tell you about that patient. He had a history of depression in the past. All right. So if you're going to diagnose depression according to the International Classification for Diseases, you need a 2-week history of sustained and pervasive low mood, usually associated with anergia, loss of energy, and anhedonia, loss of enjoyment in life. This guy presented with what we call Cotard syndrome. He was so depressed, or he appeared so depressed, that he thought he was dead. Cotard syndrome is a psychotic frame of depression that's right at the severest end of the spectrum, where people believe themselves, or either the whole body or bits of them have died. And I had this bizarre conversation with this chap, and he said, and he got very angry with me. He said, "No, I am dead." And I said, "Well, how can I have a conversation with someone who is dead?" He said, "I don't know, but I am dead." And on the basis of that, I thought, well, this must be depression. And I didn't pick up, and in fact, I didn't really get that there was a fluctuation there. In retrospect, there probably was. Believe me, it sounds as if I had been. Oh my God, there's lots of things. Right, okay, I'll go through. It sounds like I'd been a bit lax, but it really did strike me as being a depression. So Helena Worthington has said infection. Absolutely, infection. So infection post-operatively, chest infection, wound infection, urinary tract infection, especially if someone's had a catheter in. Oh, great, someone's put medication, opiates, and an anesthetic. Excellent, very good. Both of those are powerful causes of delirium. Urinary retention, yeah, absolutely. Jamie Coy, well done. Pain not adequately managed. Pain, I don't need to give this talk. You know it all. Changing the ward, fantastic. Okay, very good. Let's see. Now, my slides are frozen. Bear with me a second. Yes, Han, I'm needing help. How can I move the slide on? I'm just going to stop sharing for a second and see if it's sort of there. Share screen. Window. Okay. Right. So with Helen, we tracked down that it was pain. She was post-surgery. It was her opiate analgesia, which had made her constipated. I don't think anyone said that, but do think about that. And someone quite rightly said multiple changes. She'd had 3 changes of ward since admission. Good. Well done. So how common is this? It is extremely common. Now there are quite a few epidemiological studies, and in fact a couple of meta-analyses of epidemiological studies of delirium. And as a rule, you're looking at between 10 and 30% of inpatients at the point of admission. And that variance really depends on how you diagnose it and how assiduously the researchers look for it. And as a rule of thumb, I think stick in the middle and say 20% of people, as they walk through the ED or as they arrive on the ward, 20% of the over 65s are going to have delirium, and another 20% are going to develop it while they're there, while they're in hospital. And it changes significantly depending on the type of ward. So in the geriatric wards, it'll be up to 40%, and in ICU up to 80%. And it's not just an illness of hospital. Those of you who go into general practice, bear in mind 20% of people in care homes have an active delirium at any one time, astonishingly high. This is the one thing that I want you to take home from today. 50% of delirium is not recognized. Now, there are characteristically 2 types of delirium: hyperactive and hypoactive. Hyperactive delirium, what it says on the tin, people become very agitated, they might become aggressive, they start throwing their urine bottles around, they hit the nurses with a walking stick, they're often mobile and going up to other patients and berating them or assaulting them. Those are the ones that get recognized. The nursing staff are on them like a ton of bricks, and they will call you. 50% of delirium is hypoactive. People are sitting quietly, not causing any difficulties, but they are confused, disorientated, and it's varying over time, and they're the ones that are not picked up. Different views about the seriousness of it in terms of mortality. You'll see if you're statistically astute, this relative risk of mortality is actually not statistically significant, but the point estimate is quite significant. So from a clinical perspective, we're dealing with something that probably increases your mortality rate by 1/3. We just need larger studies to show, with enough power to show that that's the case. There are lots of anecdotes that if you have delirium, it increases mortality. And then the myth I want to dispel is that there is a myth around there that when you have delirium, if you treat it, it will get better and you'll go back to normal. That is exceptional. Most people do not go back to entire normality. Now, there's a number of reasons for that. One reason might be that it's part of a pre-existing cognitive impairment and it's now been laid bare, it's been exposed. But part of it is that delirium is quite toxic on your brain. As you get older, you have less cerebral reserve. I've seen delirium arising from profound hyponatremia, someone with a sodium of 119, never really fully recovered from that. So there's, depending on the insult, it can cause some permanent cerebral effects. This is taken from a study. I just want using the delirium rating scale, which we'll come to in a minute. And I've just put this up really to show you the the range of different symptoms that you should be looking for. So present in any severity and moderate and severe, moderate or severe severity. Sleep-wake cycle disturbance. Well, that's part of the diagnostic criterion. So you'd expect that to be nearly 100%, if not 100%. But look at this: 50% have hallucinations, 31% have delusions. 62% agitation and 62% motor retardation. So what that tells you, of course, is that there are some people here, because that must add up to 100%, there are some people here who have both agitation and retardation. Okay, I think I won't labour that slide anymore. So here are some causes. Obviously, you're very alert to these, but think infections. Urinary tract, pneumonia, cellulitis. Think cellulitis, because that's also very painful. Think about wound infections. Think about pressure sores. Changes in environment. You know, people will move from into the ITU, then out of the ITU, to HDU, then onto a ward, and then probably onto another ward, and then perhaps into a rehab ward. All of these changes have impacts. Think about medication. We've talked about opiates and we've talked about steroids. Steroids can themselves induce an extremely wide range of psychotic disturbances. People can become very manic or hypermanic with exogenous steroids. They can become depressed, and they can get a delirium type picture. And it seems to me, particularly the high potency steroids, so dexamethasone is the thing to watch here. If you give someone a big slug of dexamethasone, think 24, 48 hours later, you know, what's going on here? And then anticholinergics. This is the thing that people forget, and I want to just go on a bit about. So I want to just share this with you. This is a list of drugs, list of drugs with different anticholinergic scores. This column is mild, this is moderate, these are the drugs that have significant anticholinergic activities. Most of them are psychiatric, but you know, there's some surprises here. So take paroxetine, for example, commonly used antidepressant. I never use it, but it's commonly used, which is significantly anticholinergic. Acetylcholine was established in the 1970s and 80s that acetylcholine is directly proportionally linked to cerebral function and particularly memory. If you have a significant reduction in acetylcholine function, and if you become functionally depleted in acetylcholine, you will become more confused. These drugs will add to confusion. And what I want to point out here is that this one, that a lot of people will reach for the quetiapine, second generation antipsychotic, will say, oh, let's give them some quetiapine because they're delirious. Now, quetiapine will seemingly knock delirium on the head because it's a very dirty drug and it's antihistaminergic. It's very good at sedating people, but it's also very good at making people more confused. We'll talk a little bit more about antipsychotics in management of delirium later. Okay. Alcohol withdrawal. Watch the person who 3 days after admission, they might have had surgery or they're, you know, whatever, they're in hospital, they've been there for 3 days, and it's usually 3 days, and they suddenly become very agitated. They develop severe tremor, so severe that people can actually shake themselves off the bed with this tremor. They hallucinate, and they have archetypal Lilliputian hallucinations. Lilliputian hallucinations are hallucinations of something that's very real but very small. So an elephant the size of a penny piece, a football team playing a game of football on a tray table. These are the sorts of hallucinations that you see. That's the time to reach for your chlordiazepoxide and give big slugs of vitamin B. Surgery, pain, yes, look at renal and liver impairment. Hypoxia is a big one. So I'm going to tell you about my dear old mum, who did have mild vascular dementia, and she developed pneumonia, potent reason to become hypoxic. And she was moved from one ward to another in a hospital. It was only about a 15-minute walk. There was a porter who had her in a chair, and I was with her. I walked with her from one ward to the other. When she left the first ward, she was absolutely fine. When she arrived at the second ward, she thought she was in Italy on a holiday, and she started talking Italian with one of the nurses. She'd become delirious in 15 minutes. When they took her SATs, her SATs had fallen to 87%, and that was enough. Sorry, I'm pointing the wrong. That was enough to cause her to become delirious in that very short space of time. Then hyponatremia, I've mentioned. Basically, if you've got a sodium of above 125, it's probably not going to cause you that much harm in terms of delirium. Below 125 and certainly below 120, then you're really in difficulty there. And watch it. Don't put the sodium back up too quickly. If you've done all this, you can't find any causes, think stroke. And it might be a silent stroke, and it might not be a stroke that's particularly impacting on long-term cognitive function, but a stroke anywhere can cause delirium. And I want you to bear this in mind, because this is something that drives me to distraction. You know, the conversation goes like this: oh, well, have you ruled out, it could be a stroke. Oh no, we did a CT scan and there's nothing acute. Go and look at the false negative rates of CT scans for strokes. 10% of supratentorial, 30% of infratentorial strokes are missed on CT scans. So just because a CT scan doesn't show a stroke doesn't mean they haven't had it. Encephalitis, rare, but flavor of the month, the neurologists seem to be diagnosing this all the time now. Then these very, very prosaic, very pedestrian things that are really important, usually an add-on to something else or multiple other things. But think, are they constipated? Are they in urinary retention? Are they dehydrated? Okay, good. Don't be satisfied with finding one cause. Delirium almost always has multiple causes. Let's see if there's any more questions. Is delirium a clinical diagnosis? Any screening tools? Coming to that in just a minute. Okay, and I need to clearly I need to stop sharing and start again. It's the only way I can get to. Right, okay. So I want to think about the predisposing factors. I'm going to point you at the end of this talk to the nice guidance on delirium, and that's big about that bigs up avoidance, and I think avoidance is becoming increasingly recognized as useful. So when you are admitting someone, think about the predisposing factors for delirium and actively manage those if you can. Obviously, you can't actively manage advancing age, but you can increase surveillance. Basically, straight line, as we get older, our risk of delirium increases. It's also, of course, a disorder of younger people, so kids get it, but that's not my specialty. But really, once you're over 65, you're in the territory of having significant risk of delirium. Undetected dementia, as we've said. Impaired activities of daily living alone is a risk factor, but that's possibly a proxy for undiagnosed dementia. People who are immobile and who have sensory impairments. People who have visual impairments and hearing impairments are at significant increased risk of developing delirium. Catheterization, malnutrition, alcohol use outside the context of delirium tremens can cause delirium, and interestingly, depression. Someone asked about screening tools. I am not a great fan of screening tools on the whole for doctors, because I think that doctors have got what we call clinical acumen, and you will develop your clinical acumen, and that usually trumps screening tools. However, the confusion assessment method I will commend to you. This is so simple. You need an acute onset or a fluctuating course, and you need to be inattentive, and either disorganized thinking or altered level of consciousness. And if you have 1 and 2, and or 3 or 4, you have delirium. This is so simple and so useful. A lot of EDs now incorporate this into their documentation, and a lot of geriatric wards have it to hand. Use it. Psychometrically, it's very good. What I want to point out to you here is not the sensitivity and specificity necessarily, but the positive predictive value, which I think in terms of clinical utility is much more important. So just to remind you, the positive predictive value is, if someone scores positive for this test, what's the likelihood they have this condition? Well, if you score positive on the CAM, you have a 90% plus chance of having delirium. Now, in psychiatric terms, tests never really get better than that. That is excellent. So use it. How do you manage delirium? Well, anticipate it and modify your risk factors. Keep the electrolytes okay. Keep someone hydrated. Make sure they're adequately nourished. If they look malnourished, get a dietitian in quickly. Make sure that if you start someone on opiates, you're monitoring for constipation. You're monitoring for urinary retention. Do those things actively. If you can stop delirium starting, that is so much better. Suspect it early. And if you've now liaison teams up and down the country, psychiatric liaison teams vary quite considerably in their approach to delirium. But I think a good psychiatric liaison team should jointly, proactively manage delirium with you. You don't need to refer every single case of delirium. If it's clear-cut and you can manage yourselves, that's fine. But if you're stuck at all, get the psychiatric liaison team in. Treat the causes. Now, so if you read the books, they say, oh, you've got to nurse this person in a single room, which is well lit, have a big clock on the wall, have a calendar, use the same member of staff all day, have family members in, yada, yada, yada. Yeah, I have never seen a hospital that can have those facilities for everybody with delirium. You know, a simple head count of delirium in an average district general hospital, you're going to have probably upwards of 100 people. You're never going to have 100 single rooms. You're not going to have a single member of staff nursing someone all day. That never happens. This is, in my view, pie in the sky. And all it's going to do, if you start saying this to the nursing staff, is lead to conflict. If you can do it, brilliant, fantastic. The evidence base for it isn't great. It's intuitive and heuristic, but this is good for one reason, which is it gives everyone else in the bay a better, more restful night's sleep if you've got the person with delirium separated from them. But good luck trying to find that. Where you're left with in terms of treating delirium is a complete dog's breakfast. There have been a lot of studies. A lot of the studies are small. A lot of the studies are very poorly put together. The amount of high quality research in delirium is extremely low. NICE will say use low dose antipsychotics, maybe haloperidol for a week. I have to say that the evidence base for antipsychotics is extremely weak. Those studies that have been done, that have reported, often show that there's no effect, and meta-analyses of antipsychotic studies show that there's no effect. At best, what you might do is bring forward the time to resolution by a day or two. Balance that against the fact that, and this is an indelible fact, that antipsychotics in the elderly lead to premature death. And this is only on the basis of one study, but it was a large study, 72,000, I think, American veterans, and a potentially confounded, I will admit that, a potentially confounded study. But of all of the antipsychotics, haloperidol appears to be more effective at killing people than the others. So we're between a rock and a hard place. On the one hand, you've got quite a lot of imperatives to try to keep that person safe from harming themselves and harming other people. And you've got a responsibility to the good management and safe management of the ward. On the other hand, we have at our disposal drugs which at best are possibly ineffective and at worst might increase risks substantially. I would say that as an F1 or an F2, I would always take advice before going down that route. The other thing that I have used, you will not get this in guidelines, but I think sometimes low doses of short-acting benzodiazepines just to take the edge off. And lorazepam, 500 micrograms of lorazepam, orally or IM, one dose can often improve a very difficult situation. Again, it has its own side effects. It will increase the risk of falls. You might need, if you're not careful and you over sedate someone, well, you can reverse it, but watch that. But basically, you are poking around in the dark when it comes to using medication with delirium. Quite often, you have to just wait, treat the causes, and wait. 3 things I never want to hear from an F1. The urine dip is clear. So these are all things that have been said to me. on the wards. The urine dip is clear, so it's not delirium. Two things wrong with that. They haven't thought about the multitudinous other reasons why people might get delirium, and urine dips have got a really bad reputation in terms of sensitivity and specificity. Second thing is, we started antibiotics 3 days ago, and she's still confused. Very few studies look at the longevity of delirium after onset, and I've already told you right at the beginning that most people won't make a full recovery. But what we can say is, if you are going to make a recovery, it's probably more like 3 weeks, not 3 days. And the third thing I never want to hear is, she's confused but fit for discharge. Absolutely not. Confusion is a symptom that is absolutely merits explanation and potentially treatment. No one is fit for discharge in my book if they have an undiagnosed, unmanaged confusional state. So that's all I want to say. I want to commend you to the NICE guidance. It was updated in 2019, but it's been knocking around for many years now in pretty much the same state. Look particularly at the anticipation of delirium and managing it before it becomes florid. And please, this generation of F1s going through now, I want you to change that statistic so that 80%, that's 50% who are not diagnosed, we're getting that right down so that most people with delirium get diagnosed. Okay, let's have a look at a few more questions. Examples of disorganized thinking. Well, of course, disorganized thinking in the psychiatric sense often refers to formal thought disorder that you see in schizophrenia. But disorganized thinking is really just that you're not able to follow a logical train of thought. So the definition of formal thought disorder is failing to follow the semantic and syntactic rules of language. For linguistics among us, what that means is that you're not using speech in the grammatical structure that makes it intelligible to other people. The tip I would give for you here is, if you're talking to someone and they're talking back to you, imagine that you're taking a medical history in the ED, and you're writing things, you want to write your notes down, and you're talking to someone and they're talking back to you. You're seemingly having a dialogue, but you've not written anything down. Think to yourself, what's going wrong here? Normally, when I talk to someone and when I ask them a question, they give me an answer, I write it down. I've not written anything down. Why is that? And that's probably you're looking at disorganized thinking. Okay. How do you distinguish delirium from late onset schizophrenia? Excellent. Right. So late onset schizophrenia is phenotypically quite different from the schizophrenia you see that has onset in your teens, late teens, early 20s, in a number of ways. So in a nutshell, people with late onset schizophrenia tend to be immensely florid. They have hugely fascinating, usually, and all-encompassing delusions, often a whole matrix of different delusions. So I just give you one example. A patient of mine who thought that there was a spaceship that was controlling her mind. There were 5 people on this spaceship and she could hear them talking about her. So she had third-person auditory hallucinations. They were extracampine auditory hallucinations because they were right up in the sky and she could still hear them. They created what she called the Iron Force radar beam, and she told me this convoluted story about how these 5 people in the spaceship manufacture this radar beam and send it down from the satellite. They follow her around, and wherever she is, the beam hits her and it makes her vibrate. She was getting tactile hallucinations. That's another common thing in late onset schizophrenia, is multimodal hallucinations. The fluidity and the stability of these psychotic phenomena was really quite incredible. People with younger onset schizophrenia, the delusional base tends to be less stable. It might be 1 or 2 things. There isn't a whole panoply of different intertwined, interlocking delusional themes. Back to the question, how can you distinguish delirium from late onset schizophrenia? People with late onset schizophrenia are usually lucid, so they don't have the confusional element. They know where they are, they know who they are, they know who they're talking to. They're not acting, they're not inattentive. They're very often very attentive, but they are floridly psychotic. Can a patient have insight into their delirium? Wow. Sometimes, I think, is the answer. Yes, they can actually. So here's the thing. And I think this isn't, I've never read this anywhere, but this is from my own personal observation of many years of managing delirium. If I have someone with schizophrenia and they have a delusion that the nurses are Nazis who are ganging up against them and going to kill them, and I treat that schizophrenia, and I ask that patient to revisit that delusion once they've become non-psychotic, they can't do that. And they will usually parry that question. They'll usually say, oh, it didn't happen, or I don't remember, or I'm not sure, I don't know what was going on. But they'll never give you a chapter and verse description of the delusions that they're experiencing. And there's a reason for that, which I won't go into now, but it's a very coherent reason about why, about delusional states being ultimately non-understandable, and people are trying to put a metaphorical interpretation onto what's going on in their mind. That's all I'll say about that, unless someone wants to elaborate later. With delirium, when someone recovers from delirium, if they recover from it, and you go back and you say, do you remember what? Oh, yes. And they will give you chapter and verse. They will give you a meticulous account of the delusions and the hallucinations that they had. So there is insight there. It's often insight post hoc. You will quite often meet people who in the morning, when they are not overtly delirious, be able to recall things from the night before. And this is quite distinct from functional psychotic processes. Okay, great question. How long does delirium typically take to resolve? As I said, probably 2 to 3 weeks. Now, very good question. Appropriate level for discharge. So it depends on a lot of things. It depends on the cause of delirium. It depends how effectively you've treated it. It depends on the trajectory, how quickly they're getting better. It depends whether you're needing to medicate them. I'd be quite cautious about sending someone home if they're still requiring medication for delirium. And it depends what they've got at home, very importantly. So an elderly person going back to their own home who is delirious, that's a no-no. You can't do that. They would need to go maybe into intermediate care. One of the problems, one of the bugbears I have about rehab services is they often won't take people who are confused. Now, I'm just going to give you an example of a patient I saw today by video link, who I first saw in 2018 at the Royal London Hospital following a traumatic brain injury. And at that time, he was almost abullic. He could hardly string 2 words together. When I saw him today, he appeared entirely normal, virtually entirely normal. They're very, very minor things. Now, he needed a huge amount of both physical and psychological rehabilitation, and he did not get that in the NHS. He recovered because he actually managed to get himself into the Nightingale Hospital and had good physiotherapy and psychological support in the private sector. And I think that, and this is a slightly political statement, but I'm not really, but I think that rehabilitation services should be open to people who have confusion, because quite often with good rehab, depending on the cause, not with dementia, but if it's delirium, depending on the cause, you just wonder whether good rehabilitation will improve them further. Okay. Does having delirium once increase your risk of future delirium? Absolutely, it does. Yes. So previous delirium begets future delirium, and here is the thing: it's often the same phenotype. And going back to that guy I misdiagnosed with depression, who I thought had Cotard syndrome, who improved within a few days. He went home. 6 months later, he was back in with exactly the same symptoms, exactly the same presentation. And this time I could look very clever to my F1 and say, oh, actually, I don't think that's depression. I think that's delirium. And of course it was. Yes. So it often recurs, and it often looks the same. ICU delirium is commonly discussed by the medics in critical care environment on placement. How is this ideally managed? Get them out of ITU. 80% of people on ICU have delirium. There are so many things going on in ICU, so many. It is just, I mean, cast your mind back to the first time you went onto a medical ward, the first clinical placement you had, and how anxiety provoking and confusing that was. It's an alien environment. It now feels completely at home to you. But at the time, I bet you, the first time you went on the ward, you were a bit scared. You were scared of the nurses. You didn't know what was going on. You didn't know what to touch. You didn't know who was who. Then cast your mind back to the first time you went to an ICU, and you had that all over again. Now imagine someone who is hospital naive, and suddenly they end up on ITU, and they've got horrible things going on with them that are requiring ICU support. It's not surprising that they have high levels of delirium. You manage it by managing everything that I've talked about in terms of the physical causes and getting them off ICU as quickly as possible. Okay, we are at 7:45. I said I'd go on for 45 minutes. Any more questions? I don't see any more. But that's been a great set of questions. Thank you very much. I'm going to finish now by just reminding you of just a couple of key points. Think delirium from day one. Anticipate it and manage it by avoiding it if you can, and be cautious about using any prescribed medication in the management of delirium. One final question, Jamie. If we anticipated that a patient is at high risk of developing delirium with their comorbidities, can we prevent it before delirium before it occurs? Not a huge amount of strong evidence on this, but yes, I think that a proportion of people with delirium, it is preventable. It's certainly worth a try. Well, no, absolutely it is. If you see someone's sodium climbing, they're going dehydrated. Don't wait till they've got a sodium of 150 before you start giving them fluids. Make sure that you're getting their fluids in slowly. You don't want to get a central pontine myelinolysis, but yeah, yes, anticipate and manage it, and I think you will have a lower rate of delirium. Absolutely. Guys, thank you very much for clocking in this afternoon. I hope you have a great evening, and just want to say thank you very much again for attending, and have a good night. Bye-bye.